Hello, Team Pinehurst, and happy Friday. Today, I want to talk briefly about supporting documentation for HCCs, including requirements, restrictions, what we actually need from providers. But first, why is documentation so important for risk adjustment? We know that clear and concise medical record documentation is critical to providing patients with quality care and is required for providers to receive accurate and timely payments. Complete documentation will also assist providers in meeting requirements for quality measures such as SARS, HEDIS, MIPS, and MACRA. Finally, if you fail to document an HCC diagnosis, that doesn't mean that you're still not doing the work, taking care of the patient, and really assessing the diagnosis. You're just forgoing the credit, recognition, and reimbursement for the disease burden that you are actually taking care of. CMS does have some requirements and restrictions relating to HCC diagnoses for risk adjustment purposes. The basic CMS requirements are: any disease or disorder reported for a patient must be supported by documentation showing that the condition is active, accurate, and being followed or managed. Providers are supposed to document all health conditions, including those that coexist at the time of a visit. This includes chronic illnesses and status codes, as well as chronic or known conditions from specialists, labs, diagnostic imaging, and more. Diagnoses must be explicitly stated by the provider in the documentation and as text. Diagnoses cannot be inferred from unsupported ICD-10 codes, lab values, medications, or anything else. All diagnoses must be identified and assessed during a face-to-face visit, and all diagnoses must be reassessed by a provider and added to a claim at least once every calendar year. In addition to these requirements, there are also some coder restrictions. First, coders cannot use medication lists as supporting documentation unless there is a clear link to the diagnosis stated from the medication. Codes added without narrative or support in the documentation are truly invisible to coders and will not be added to the claim or would be removed. These are also a very big audit risk. Coder will look for support throughout the note, not only in the A&P, but also in the HPI, physical, review of systems, or anywhere else that is not a cloned list of problems. Coders cannot accept any diagnoses that are unconfirmed, things that state likely, probable, suspected, or terms like that. Coders cannot infer or assume a diagnosis or a specificity with a diagnosis based on orders, labs, imaging, etc. And finally, coders cannot accept ICD-10 codes without words as supported, or accept any arrows or other symbols as support. So I-10 would not be appropriate as for hypertension. It would need to say hypertension. When reviewing charts, we are keeping these requirements and restrictions in mind while looking for diagnoses that were assessed and then confirming that there is an appropriate element of supporting documentation for each. The acronym of TAMPER lists specific elements that we look for which establish the diagnosis as active and accurate and also ensure proper support. So my coders and I really ask ourselves, did the provider tamper with the diagnosis? Or basically, is there supporting documentation showing that the provider is treating, assessing, monitoring, medicating, planning, evaluating, or referring specific to each diagnosis? I do want to note that only one element of tamper is needed in the documentation to have approved support. The chart on the right shows what element each letter of tamper stands for, along with some examples that are included in that element. For T, we are looking to see if the provider is treating the diagnosis. Things like ordering labs or tests, providing education or counseling, or discussing therapy or potential procedures are examples of documentation that shows the diagnosis is being treated. A is for assess. Is the provider assessing the diagnosis? Stating the stage or status of a condition would show that it's being assessed. M is for monitor or medicate. Ordering or referencing labs or other tests would show that a diagnosis is being monitored. Prescribing, adjusting, or refilling medications would show the support for medication. P is for plan. Current management or follow-up would show the planning element. E is for evaluate, which would be through a physical exam or other evaluation of the diagnosis. And finally, R is for refer. A referral to a specialist or for a consult or procedure would show the element of the diagnosis being referred for. I do want to point out that showing proof of tampering with a diagnosis is not always difficult and doesn't always require a lot of documentation from providers. This chart lists simple words or short phrases that, when documented with a diagnosis, sufficiently show that the diagnosis is active, accurate, and being managed. For example, AFib, stable, is sufficient to show support for AFib. Severe CKD would be adequate documentation to support CKD stage 4. And any of these other words or phrases are also fully showing support for a diagnosis. As a final point, I did include some HCC documentation best practices. As a PCP, even if a specialist is fully managing the condition, you should still address and document the diagnosis, even if it's something as simple as stating seeing pulmonology for COPD. Be sure to list all HCC diagnoses within the first 12 spots on the claim when possible. Be sure to connect the dots since coders cannot. So when you're stating the GFR value, connect that to the associated stage of CKD. Or when refilling a medication, document that it's for the diagnosis that you're prescribing it for. Documentation should be as specific as possible so that the diagnoses coded can be as specific as possible. This can sometimes lead to higher levels of reimbursement as well. Don't forget status codes or things like amputations or transplants. Those are easily missed, but easy to capture. History of should only be used for diagnoses that truly no longer exist. Try to avoid using history of for diagnoses that exist but are currently controlled or stable. Finally, as we are now reviewing some patients in a concurrent format, please watch out for queries from your coder. These will have some questions on missing documentation or conflicting documentation. Thank you, and as always, if you have any questions or concerns, please don't hesitate to reach out.